was weaned off. He was removed from ventilatory support just next day, and inotrope support were completely removed in next 2 to 3 days, and ECMO support was weaned off in next 2 to 3 days also. And finally, he went home walking. His LV function improved from 15 to 20% to 45 to 50%, and on follow-up, he is doing so well. So this is the example of immediate life supports which should be given when you have an aggressive attitude to these kind of patient, that we have to manage this patient, otherwise this patient is going to die. This is the third case. The patient, he was a case of resuscitated cardiogenic shock. He presented to us in our emergency department in an intubated state. He was intubated in the emergency, and he was immediately rushed to the cath lab, where he was put on IABP support. Urgent coronary angiogram was done, and coronary angiogram revealed that there was complete occlusion of his left anterior descending as well as his right coronary artery. So what we planned, we immediately opened his left anterior descending artery, but his pressures were not improving even after high dose adrenaline, high dose noradrenaline, IABP support. His pressures were not going beyond 60-70 systolic blood pressure. So we planned that we will open his right coronary artery also, because there was no hope. He was in a phase of doom that he may collapse. So his right coronary artery was also opened, but in spite of that, his pressures were not improving that much. His systolic pressure hardly went up to 70, 60 systolic. So he was immediately put on ECMO support. Gradually, he was weaned off from ECMO support, ventilatory support, and multiple inotrope dose support. Physiotherapy was started. Gradually he was improving, but it was sad for us that almost after 10 to 12 days he succumbed to ventilatory associated pneumonia. He was again reintubated due to chest infection. We are now and then we are every day we are doing IVUS guided procedures, and also as per the new recommendation of ACC, every complex angioplasty has to be done with coronary imaging, whether IVUS, whether OCT. And whenever it comes to left main, it is almost mandatory that you should do a coronary imaging. Doing left main intervention in absence of coronary imaging is just like doing a crime. We are almost blindfolded that what we are exactly giving the result to the patient. So that has to be given to the patient. So this is a case of IVUS guided ostial left main angioplasty in a patient. This patient presented to us with non-STEMI cardiogenic shock. He was put on inotrope support, and on angiogram it revealed that there was a ostial left main stenosis. It was almost 90 to 95% stenosis. His right coronary artery was near to normal. So he was counseled for urgent surgery, but as we know that families and patients in Bihar usually, whenever they hear of CABG or open heart surgery, they usually want some time. But this was not a case that time should be given. And finally, his family denied for CABG, and they said that you have to go with angioplasty. So we put that patient on IABP support. A coronary angioplasty of left main was done under IVUS guidance, and this was the final result which we achieved, and patient was weaned off from IABP support. Just next day inotrope support were completely removed next day up till evening, and he was discharged 2 days after the procedure. These are the IVUS images which were obtained. We can see that the ostia of left main, there has been significant stenosis at the ostia. So the benefit of IVUS in this patient was that whenever we are touching left main, the results of our stenting, that should be perfect. So we can see that there has been complete apposition of stent to the left main, especially at the ostia. Otherwise this patient will again come back in no time with stent thrombosis or a rapid stent in-stent restenosis, ISR, which we call. This is we are also doing the newer techniques which are used for calcium management when we are doing coronary angioplasty. So this is an example of rota ablation guided angioplasty in a critical LAD stenosis. Basically, rota ablation, we use a small diamond burr which cuts the calcium with a very high speed rotation at a speed of almost 1,60,000 to 1,80,000 rotations per minute. This is used to crack the calcium so that our stent delivery and expansion of the stent is well achieved. And as a result of that, the issues of stent restenosis and issues of stent thrombosis, they are curtailed down as much as possible. So this is the case. A critical stenosis of LED was seen. We did rotablation, and final angioplasty result was obtained in this patient. And this patient is doing well almost. There has been 6 to 7 months of doing this procedure. These are the IVUS results. We can see a 270-degree calcification in LED, and final results after stenting were wonderful. We also do rotatripsy. Rotatripsy is a new modality in which we combine rotablation with IVL. At times we do not achieve that results after rotablation. The calcium, cracking of calcium is not that much possible whenever there is almost 360 degree or 270 degree even deep calcium. In that case, after rotablation, we have to use intravascular lithotripsy. Basically, it is a minor form of lithotripsy which is being done for renal calculi. Now it is being applied for coronary calcium. So this is a case of distal calcific stenosis of RCA, in which rotablation was initially done, but the calcium was not cracked up till that much. So we used IVL balloon for that, and after IVL balloon we did stenting, and this was the final result which we obtained. So there was a good extent expansion which was observed, and the patient is doing well, not any signs of clinical signs of stent ISR or stent thrombosis up till now. We also are doing high risk procedures in elderly patients. So this is a case of graft vessel angioplasty which was done in an 84-year-old male. Basically IVUS support is required for these patients, and the results were wonderful, and the patient is doing very well because these patients are not a candidate for reduced CABG. We also use OCT for better stent results. So we can see with use of OCT a good stent apposition and optimization which was achieved in this patient especially. In case of structural intervention, we are doing TAVR, transcatheter aortic valve replacement. High risk patients undergo aortic valve replacement without any open heart surgery. This is a case of TAVR. We also do other structural intervention. This was a difficult PDA closure which was done through retrograde access, and a good result was obtained. We also do balloon pulmonary valvotomy, although it is a very common procedure, but this procedure was done in a 1-year-old child, and he is doing so well now. Advanced pacing modalities, Dr. Shaheen has discussed. We are also upgrading dual chamber pacemakers to CRTs for recurrent heart failure, and we are also doing left bundle pacing in our patients. Thank you.
Thank you. First, I congratulate the Medanta team for saving the critical patient life. It is very boon for our state that we are saving such type of handling such type of critical cases. But in medical science, always a learning curve for doctors, state and hospitals. And it is a very important, the group practice is very important. How can you save the critical patient? And when you treat the complex cases, there is always a risk of complication. How will handle the complication? This is the most important aspect. And if you have a team, if you have a hardware, you have all the possible